In this lecture, we will continue the third part of the subject impression for a crown and the bridgework. We will deal with gingival retraction is a procedure by which we expose our gingival finishing line that is located subgingivally so that we can take a good impression that involves the details of the end margin of the preparation that is located subgingivally. Requirements of gingival retraction materials. Histologically, we have the gingival sulcus, which has a mean depth of 2 millimeters. Then we have lined by the cellular epithelium. Then we have the junctional epithelium, and then the connective tissue attachment. The combination of the connective tissue attachment and the junctional epithelium is called the biological width. During tooth preparation, we should not violate the biological width. Otherwise, we will end with gum recession in the future. The retraction material, regardless of its type and its mode of action, should have the following requirements. First, the retraction material should act within the area of the gingival sulcus only. That's to say, within the free gingiva, and should not cause any trauma to the underlying junctional epithelium. Second, the retraction material should provide retraction of the gingival tissue for a time long enough to take the final impression. Meanwhile, the retraction should be transient, reversible, and allow recovery of the displaced gingival tissue. Upon application of the retraction material, 4 forces will act together on the gingival tissue as seen in the following figure. The retraction force, which tends to retract the gingiva vertically. Displacement force, which tends to displace the gingiva horizontally. Collapsing force and relapsing force. The collapsing and relapsing forces tend to recover the gingiva back to its original level. Therefore, to provide efficient gingival retraction, the retraction material should be able to overcome the collapsing and relapsing forces. The fiber-rich, highly organized periodontal complex supporting the natural teeth provides support for the gingival tissue when they are retracted, mitigating the collapse of the tissues when the retraction agent is removed before making the impression. Objectives of gingival retraction. First, to create an access for the impression material to the area of the preparation that is located subgingivally. Second, to provide enough thickness of the impression material at the area of the finishing line to prevent tearing or distortion of the impression material. Third, to control the amount of fluid seepage in the gingival sulcus that might cause voids in the impression, as most of the impression materials are hydrophobic. Techniques of gingival retraction. We have mechanical, chemomechanical, retraction paste or so-called cordless technique, electrosurgery, and laser. In the mechanical retraction, either by the use of a plain retraction cord or the use of Teflon tape or a temporary crown with a slightly overextended margin left for 24 hours. This will provide gingival retraction. The use of Teflon tape is a new trend in gingival retraction. Retraction cord. The retraction cord is a special cord made of cotton which comes either plain, free of medicament, or pre-impregnated with a medicament, usually a vasoconstrictor. Using a plain retraction cord is considered as a mechanical means of retraction only. The retraction cord could be either knitted, braided, or twisted. Knitted cord will expand after its placement, providing, as we say, the retraction cord may be knitted, braided, or twisted. This is a microscopical image or picture of the retraction cord, showing the fine filaments of the retraction cord. Retraction cord comes in different sizes, 6 different sizes: 30, 20, 0, 1, 2, and 3. Techniques of gingival retraction using retraction cord. The retraction cord can be used with either of the following techniques: either single cord technique, in which a single cord is placed in the sulcus after tooth preparation, or double cord technique, in which 2 cords are placed in the sulcus. A thin cord is placed in the depth of the sulcus prior to the completion of tooth preparation. Then a thicker cord is placed above the first cord after completing the tooth preparation. The thin cord will provide vertical displacement of the gingival sulcus, while the second cord will provide horizontal displacement of the gingival sulcus. The double cord technique is used when we have deep subgingival margin where a greater retraction is needed. The first cord is usually placed in the depth of the sulcus prior to tooth preparation, as we have mentioned previously. This will provide vertical displacement and will protect the gingival tissue during margin finishing. The second cord is then placed after completing tooth preparation to provide horizontal displacement. This video shows finalization of the preparation of the finishing line with the presence of the first cord. The retraction cord is placed in the sulcus using a special instrument called cord packer, starting from the interproximal area, and during the placement of the cord, it is better to support the cord using another instrument such as a periodontal probe to avoid the slippage of the sulcus during its placement. Sizes of the retraction cord. Size 3-0 and 2-0 are both recommended for anterior teeth with minimal clavicular space, and also can be used as a primary cord in the double cord technique. Size 0 and 1 both are recommended for bicuspids, and size 0 is used as a primary chord for the double chord technique, while size 1 could be used as a secondary chord. Sizes 2 and 3 are recommended for molars with thick gingival biotype. The required length of the retraction cord is cut according to the diameter of the tooth. Then the retraction cord is packed inside the sulcus all around the tooth using the Fisher's packing instrument. The retraction cord is left inside the gingival sulcus all around the tooth for about 10 minutes. The cord is then removed, leaving the gingival tissue in an expanded state. It is better to moisten the retraction cord prior to its removal from the gingival sulcus, as it might cause tearing of the sulcular epithelium. The retraction cord, after its removal, will provide a space to inject the impression material all around the tooth at the area of the finishing line by the use of an impression syringe. Chemomechanics. In the chemomechanics, a retraction cord impregnated with a vasoconstrictor. Impregnated with a medicament. The medicament might be aluminum chloride, epinephrine, or ferric sulfate. The same procedure for placement of the medicated cord is used as for the plain retraction cord. Each one of these medications has advantages and disadvantages, but the most commonly used medication is the aluminum chloride. Either the cord comes pre-impregnated with the medicament, or we can use a plain cord, then we impregnate it with a hemostatic agent such as the astringent X from Ultradent company, which contains aluminum chloride. The third technique of gingival retraction is the retraction paste or cordless technique. This is a new class of gingival retraction materials that have been introduced, and these were introduced in order to overcome the disadvantages of retraction cord, which is the long time required for application of the gingival retraction cord, and the technique difficulty and the pain encountered during placement of the cord. Moreover, the retraction cord might cause injury to the sulcular epithelium. Therefore, a new class of retraction materials has been introduced in the form of paste or gel, and these have been, when assessed histologically, they were found to be more tissue friendly and does not cause injury to the gingival tissue. The first one and most widely used gingival retraction paste is X-Pasil. The X-Pasil is composed of kaolin and aluminum chloride 15%. The material is supplied in the form of carpules that are attached to
reduce
a
the
special
pain and potential epithelial attachment damage and bleeding caused by
gun.
traditional retraction techniques, Acteon offers Expasil paste. With no cord, clinicians can achieve predictable retraction and
Expasil
reliable
is
hemostasis.
injected all
The starter
around
kit
the
comes with 6
prepared
reusable capsules
tooth
of retraction
and
paste,
left
12
inside
applicator tips,
for
and a manual
To reduce the
about
pain
2
and potential
minutes.
epithelial
So
attachment
the
damage
time
and bleeding
required
caused by
for
traditional retraction
replacement
techniques,
of the
Acteon offers Expasil
retraction
paste.
paste
With no
is
cord,
less
clinicians
than
can
that
achieve
of
predictable retraction and
cord.
reliable hemostasis.
Moreover,
The starter kit comes with 6 reusable capsules of retraction paste, 12 applicator tips, and a manual applicator.
It is
After
painless
placing the paste in the sulcus,
and
which takes
more,
about 20 seconds, it's
and
left in
it is
place for 1
easier
minute.
than the
You can
placement
get up to a
of
half
cord.
millimeter of sulcus opening that lasts
However,
for up to 2 minutes.
The use of retraction paste is more expensive than cord. Another retraction paste is the Magic Foam cord, introduced or developed by Colting Company. It is a form of polyvinyl siloxane, expanding type polyvinyl siloxane, addition type silicone elastomer. After we complete the tooth preparation, we inject the material using a current dispenser as for light body impression material. Then a special cap called Compre cap made of cotton supplied with the kit is placed over the injected material, and the patient is asked to bite on it for 5 minutes. This material will act by mechanically by causing by the expansion of the polyvinyl siloxane and by the pressure exerted by the Compre cap. So this material acts purely mechanical, while the Expasil acts in 2 ways. It acts mechanically by the presence of the kaolin that will absorb the moisture present in the gingival sulcus and expand. Its expansion will cause mechanical displacement of the gingival tissue, and it will the other mode of action of Expasil is that it acts chemically on the gingival tissue due to the presence of the aluminum chloride, which causes gingival ischemia and thus cause retraction of the tissue. This material was developed by 3M Company. It is supplied in the form of campules, unidose campules that has a fine tip with marking on it to aid in the placement inside the gingival sulcus. The astringent retraction paste has a chemical composition of Expasil. It is composed of kaolin, which is aluminum silicate hydrate, aluminum chloride 15%, mica, water, and polydimethyl siloxane. The material is injected around the prepared tooth and left for 2 minutes, then washed away and will provide gingival retraction. The other technique is the use of electrosurgery. Electrosurgery will cut the gingival tissue with the advantage of controlling post-hemorrhage post-surgical hemorrhage. However, electrosurgery should not be used when there is gingival inflammation or periodontal disease. Laser. Most of the time for gingival retraction, diode laser is used in the troughing mode, where the tip of the laser is used to shave the inside of the gingival sulcus to provide troughing of the gingival tissue. It is claimed that laser therapy does not require anesthesia. Laser procedure minimizes bleeding and bacterial infections are minimized. Wounds heal faster and tissues can be regenerated. However, the disadvantage of laser is that it is a slow technique and expensive. Finally,